Hi, welcome, and hope you have a fun lunch or learn today. My name is Dr. Olazagasti, but we will be talking about functional GI disorders. I have no disclosure for this topic, and the objectives will include the functional abdominal GI disorders, including abdominal pain disorders, defecation disorders, and nausea and vomiting disorders. In particular, we're looking at symptoms. We're going to be looking at how to diagnose that through a Rome-4 criteria. This is a criteria we'll explain. And we're going to learn how to diagnose and how to treat some of these conditions. The Rome criteria is a diagnostic criteria developed originally. The pioneer was George Engel, and this was back in 1980. And he developed this, what we call a psychosocial model in regards the patients, the actual individual early life factors like genetics, culture, environment, which influence the psychosocial aspects of the individual, like life stressors, personality, psychological state, how the person copes with situations, social support, but also affecting the physiology of the GI tract and the functioning. So there is a brain and gut interaction between these particular conditions. There was a group of gastroenterologists that got together and by 1994 then developed a diagnostic criteria called Rome criteria. And this was developed in Rome. Actually, they got together in Rome after a couple of years of emailing and developing all these particular aspects of how to address these particular disorders. And what is different between Rome 3 and Rome 4 is that in Rome 3, the actual diagnosis was done after any organic disease has been excluded. So that involved quite a bit of diagnostic testing that might not be necessary for these particular conditions. The new Rome 4 criteria in 2016 brings the term that after appropriate medical evaluation, the symptoms cannot be attributed to any medical condition, and then hence, you may need some testing, some selective testing or not. So these are mostly clinical diagnoses. So it depends on the clinician. They have the option or basically perform whatever selective that they may need or may not. So talking about the biopsychosocial concept that Engler developed, you see early life factors like genetics, culture, environmental factors, then affecting psychosocial factors like life stressors, etc. And then our own physiology, the motility, the sensation, the immune dysfunction or inflammation, how we eat, the altered microflora altogether acting up from the brain to the gut, and then creating some type of symptoms, severity of them, and the behaviors involved with this. Then the outcome, so healthcare needs, affecting daily functions, affecting quality of life, and not to say healthcare costs involving all these particular conditions. So let's talk about the definition. So we talk about disorders of the gut and brain interactions. These are classified by GI symptoms related to a combination of the following: motility, visceral hypersensitivity, altered mucosal and immune functions, altered microbiota, our own good or bad bacteria, and our central nervous system processing. So this diagram actually explains all this conglomerate of variable. For example, our diet, our dysbiosis, good or bad bacteria influencing our symptoms, motility, baseline motility abnormalities, our own genetics, life events, infection, any type of disordered pain processing with psychological stressors all together driving an enteric nerve stimulation, and then the symptoms, in this case, irritable bowel syndrome. Always keep in mind alarming features, red flags of any organic disease. Then talking about the biosocial model, very similar to what I already explained, our genetic predisposition, early life events, causing changes in our pain processing, our visceral hypersensitivity, and not to say sensitizing psychosocial factors, depression, family stressors, coping, secondary gains, which is very important in any pediatric patient, how the family recognize these particular events and how the patient itself may have a lot of emotional gain out of this. If there's any history of abuse, stressors, plus the other sensitizing medical events that causes abdominal pain and GI problems. So these are the three main topics we're going to be talking today. There are many other functional disorders of the GI tract, but I'm just going to concentrate to the nausea and vomiting, abdominal pain, and defecation disorders. First, let's start with the nausea and vomiting disorders. The first one is cyclic vomiting syndrome. So a patient needs 2 or more periods of intense nausea and sudden onset of vomiting lasting for hours or days within 6 more periods. Interestingly, these particular symptoms are usually stereotypical. So they have to follow this pattern. So they know if they actually are developing another episode of cyclic vomiting, or it's just a viral illness triggering vomiting and diarrhea. Again, separated by weeks of month with basically no major complications or problems. There are some pathophysiology involved with this particular scenario of symptoms. We don't know exactly why are the true triggers, but there are some mitochondrial DNA polymorphism that may be involved in dysfunction of the mitochondria. In addition to stressors triggering the corticotropin releasing factors, then triggering GI symptoms. So both together could be very important in the development of symptoms. Treatment, cyproheptadine, amitriptyline, propranolol as the major 3 medication. The cyproheptadine in less than 5 years of age, amitriptyline greater than 5 years, and propranolol at any age. The amitriptyline, for example, the dosing is 0.5 milligram per kilogram per day, usually given in 1 dose at night. Propranolol from 1 to 3 milligrams per kilogram per day. I usually start at 1 milligram, then advance to 2, depending on how symptoms are controlled. Always keeping in mind that you have to check blood pressure the first week of starting any of this propranolol in order to monitor hypotension. Acupuncture, there is a P as in Peter 6 acupuncture site in the anterior wrist. It's between these 2 tendons, and that particular point helps not only vomiting, nausea, and motion sickness, but it's also helpful in CVS. And this actually, it's one of the brand is called C-band brand, and it can be ordered, and this can be helpful in this particular patient. Also, adjunctive therapy with CoQ10, ubiquitin. CoQ10 helps cyclic vomiting syndrome by helping shuttling electrons through the membranes of the mitochondria, then helping respiration, cell respiration. The other important adjunctive therapy could be carnitine. Carnitine also channel long chain fatty acids through the membranes of the mitochondria and then helping fatty oxidation, both of them helping function and fueling the mitochondria. Some triptans, like sumatriptan, can be helpful. These are mostly migraine type of medications. The next topic is functional nausea. These are functional bothersome nausea at least twice a week for 2 months. So these patients are basically, that's mostly the only complaint. They function fine, they don't vomit, they don't necessarily have abdominal pain, and the nausea not necessarily will relate to any meals. And but the pain tells you that they're nauseous most of the time. Sometimes if they sleep through the morning on a day that they're home, they may not complain of any nausea at all. The next one is functional vomiting. Functional vomiting, you need at least all of the following over a 2-month period. For example, 1 or more episodes of vomiting per month. This is not eating disorder, so basically there's not associated with anything, bulimia or anything like that, and there's usually not abdominal pain. Both functional vomiting and functional nausea were not included in the criteria for Rome number 3, and these are specified now in Rome 4 because they had no specific location of these particular disorders, and they were not linked to, for example, cyclic vomiting or any other of the dyspepsia symptoms to actually categorize them. And these are actually true conditions that we see in our patients and mostly as a gastroenterologist. So there are always autonomic symptoms associated with vomiting or nausea. They're all like tachycardia, paleness, sweatiness, dizziness, or orthostatic symptoms. So this particular patient will complain of that they have a syncope, they were taking a shower, and they got sick when with a hot shower. So they all have this sensitivity for autonomic type of secondary symptoms linked to the functional disorder. Remember always red flags for further evaluation, organic disease to keep it in mind, like pseudo-obstruction, gastroparesis, abnormal anatomy like malrotation. The treatment for functional vomiting, there's no true data available. Cyproheptadine may have a function, and cyproheptadine can be used 1 or twice a day, keeping in mind that it can cause sleepiness, but it's a 5-HT1 agonist, and it might be helpful. The cognitive behavioral therapy and hypnotherapy might be helpful as well. And in some selective motility centers, gastric electrical stimulation may be used as well. The next topic, rumination. These are repeated regurgitation and rechewing of what the person has already just eaten. And this doesn't happen during sleep, or there's no associated with retching. So, for example, different to reflux disease, that they may have symptoms when they're sleeping, there's none in this. So the mechanism is by the person increasing abdominal muscle pressure and then increase abdominal intragastric pressure and then bringing the food into the esophagogastric junction into the thorax and then triggering exposure of gastric content. So these patients actually can tell you that they could reproduce this. So if you're in the office and you have a suspicion for rumination, you can ask them, could you make it happen? So different to reflux on any other type of scenario, they can actually reproduce that. There is linked to post-infectious processes triggering this, but mostly psychosocial stressors and psychiatric illness are linked to rumination. Emotional isolation is a big one in rumination. The patient actually does this as a sense of comfort. You see that happens when they're bored, when they're stressed as well. So differential diagnosis, of course, bulimia, anorexia nervosa, achalasia. The treatment is mostly cognitive behavioral therapy. Remember, this is a habit disorder, so this is a learned behavior that they can then need therapy, psychotherapy. Aerophagia, these patients will have a lot of problems with swallowing air, and it's mostly associated with anxiety. They'll belch a lot. They have a lot of flatus, a lot of passing gas, and it's seen also in neurocognitive disabilities like patients with cerebral palsy or spastic paraparesis, but it's mostly seen when there is a behavioral dysfunction, and treatment with behavioral therapy, psychotherapy, and benzodiazepine would be helpful. Let's talk about abdominal pain disorders, and this is functional dyspepsia as the first one. This particular patient will have 4 times a month problems with abdominal pain, and for at least 2 months, and they need at least 1 or more of these other bothersome symptoms: early satiety, postprandial fullness, or epigastric pain. So functional dyspepsia is categorized by 2 main groups: the postprandial distress syndrome, which is the early satiety, postprandial fullness, and then the epigastric pain. And when you're talking about epigastric pain, it's burning type of pain. How to treat this? But food avoidance of the food irritants, avoidance of non-steroidal anti-inflammatory medications, and keep that in mind that you can also try with cyproheptadine, but you have to address psychological factors with chronic, cognitive behavioral therapy. Hypnotherapy will be helpful, and in some more severe cases, tricyclic, like amitriptyline. Amitriptyline is also given in low doses in any of these functional disorders. We usually use 10 milligrams, and then we increase up to 25 if needed, the most 50 milligrams per day, usually give it at night. PPIs has a role mostly in the epigastric pain type of disorder, and H2 blockers as well. In some specific motility centers, gastric electrical stimulation might be helpful. So let's talk about irritable bowel syndrome. These are patients with abdominal pain at least 4 times per month for at least a couple of months. And this will have, aside from abdominal pain, changes in bowel movements, frequency of stooling, appearance of the stool, so it goes from diarrhea or constipation. And again, the abdominal pain does not necessarily resolve with the treatment for constipation. Different to functional constipation that we're going to talk later, these patients, they pass a stool and they still have rectal pain and abdominal pain because of their particular baseline of visceral hypersensitivity. The pathophysiology, again, disorder of the gut-brain axis that we already said, visceral hypersensitivity, rectal and gastric hyperalgesia. They're very sensitive for gastric distension, rectal distension. So we can see some cases where post an infection can trigger irritable bowel syndrome. We can see patients that an alteration of gut microbiome after antibiotics or infections can also be affected and develop irritable bowel, and surgery. Mostly bowel surgery can trigger symptoms of irritable bowel syndrome. This is the famous Bristol scale chart, so where we categorize the stool from type 1, which is hard constipated stools, to type 7, which is actually the diarrhea type of stools, and in between the different other type of consistencies. This diagram points irritable bowel syndrome and the 3 main aspects of constipation with Bristol type 1 and 2, diarrhea with Bristol 6 and 7, and a mixed IBS, which is actually a combination. They fluctuate with hard and diarrhea stools off and on. Treatment, probiotics may have a role. I'm not seeing much help with probiotics in the past, but I always recommend them and try. Peppermint oil is quite effective. There is an actual peppermint oil capsule that is very effective. Elimination diet, like for example, fermentable sugars that could cause abdominal distension, diarrhea. Elimination diet might be helpful. Behavioral therapy will be helpful to coping skills, to develop coping skills. Antispasmodics like Lepsin, Bentyl, psyllium fiber is very helpful in constipation, IBS with constipation, and in some specific cases, amitriptyline, mostly with patients with IBS and diarrhea, and SSRI when there is anxiety involved with the symptoms. Let's talk about abdominal migraine. So abdominal migraine and cyclic vomiting syndromes are the most severe factors in these particular functional disorders that I'm talking today. So the patient with abdominal migraine will have severe pain for at least 2 times a month for a month or more, for 6 month period of time. The pain is paroxysmal, severe, sudden, and even may last for 1 hour or more. And it's usually in the midline, but it can be also diffuse, but most of the time it's midline or periumbilical. The episodes are separated, again, like cyclic vomiting. They're pretty much fine in between this episode. Stereotypical factors. So they always had these type of symptoms that they can recognize quite easily because they repeat themselves with every symptom. Criteria, aside from the severe pain, 2 or more of this, anorexia, nausea, vomiting, headaches, photophobia, and pallor, paleness. The pathophysiology is very similar to cyclic vomiting and migraines. The triggers will involve fatigue, stress, traveling, and they're very similar to cyclic vomiting syndrome. Mechanism of pathophysiology is there are excitatory amino acids like neuropeptides or neurotransmitters that actually are linked to the severe abdominal pain. There's also factors of central nervous system areas with the temporal lobes and the amygdala relating to this excitatory a stimulation that involves the gastrointestinal tract triggering this severe pain. The differential diagnosis, we have to think about bowel obstruction, urologic obstruction, pancreatitis, genetics like familial Mediterranean fever. Think about porphyria, think about psychiatric disorders, but also you have to keep in mind metabolic disorders. Sometimes we have to look for porphyria screening, carnitine screening. We have to look for urine for organic acids, amino acids, and because sometimes if the symptoms does not get better with your treatment, there might be other organic disease that you have not actually diagnosed. The treatments, amitriptyline is a great choice. Propranolol, cyproheptadine, and valproic acid. Pizotifen can be helpful in some patients as an anti-serotonin, antihistamine. In my practice, I found that propranolol is the best treatment, but I always start with cyproheptadine, then amitriptyline, and then propranolol, depending on age as well. Let's talk about functional abdominal pain, this is functional abdominal pain syndrome. This is what we see mostly in our practice. This is the garden variety patient with abdominal pain. The pain is at least 4 times a month for at least 2 months. The pain may be episodic or continued, and it may not necessarily be doing physiological events. For example, if a lady has a menstrual cycle, they may have pain, but it's out of that also. They may have pain, very, very erratic, and there may be stressors involved. Some patients will not necessarily complain of stress when they're having this pain. And again, there's insufficient criteria for irritable bowel, functional dyspepsia, or abdominal migraine that will classify functional abdominal pain syndrome. The pathophysiology, stressful events, very important. There's no rectal hypersensitivity, so these patients actually go to the bathroom and relieve. Once they pass a stool, they get relief with the pain. If they have constipation, there might be some slow gastric emptying, not only of food but also of liquids, and the outcome depends on how the family copes. If the parents are very involved with the pain and put too much attention on the pain, there might be some emotional gain, and the patient may not cope with the pain as needed, and then they persist in this cycle of worse and worse scenario, because many parents may not believe that they have just a functional disorder. So again, clinical symptoms, there might be somatic symptoms, there might be autonomic symptoms like POTS. POTS is postural autotatic tachycardia syndrome. It's quite common in patients with functional disorders of the gastrointestinal tract. But also always remember the red flags of other alarming symptoms. Always keep that in mind, that there might be caused for other reasons, not just a functional pain. Again, this is similar of what I presented before, and we're going to go to treatment. Antispasmodics like leptin and leptin, bentyl, amitriptyline, antidepressants like Zoloft, hypnotherapy, and cognitive behavioral therapy. So let's talk about the last 2 functional disorders. I have 5 minutes, and these are for functional constipation. Again, this is a garden variety constipation that you see in the children that is toilet trained. There are 2 or more criteria for this. At least once a week, they will have problems for at least a month. So they have 2 or less stools per week, or pain on defecation, or stool withholding behavior, or very large caliber stools, or fecal incontinence. If you have any question, a rectal exam will tell you a big fecal mass in the rectum. The incidence is 13% in children. Their pick is at toilet training, of course, because they get feared to use the bathroom. the boys are higher in an incidence of fecal incontinence, but in reality, the incidence is similar to boys and girls. And not only that, also in socioeconomic classes of cultural dietary practices. So basically equal in all these areas. The major triggers are withholding due to pain, because they don't want to use the bathroom at school, or they don't want a bathroom outside home, and that triggers problems with withholding. These are the alarming features of other organic diseases. Again, the treatment, you have to clean this patient very well first, and then do maintenance. So we use Miralax, we use magnesium citrate, and we use some stimulants during the fecal disinfection, and then maintenance to actually maintain the soft stools. Half of the patients respond by 6 to 12 months of the diagnosis. Education is very important. You need to sit with the patient and the parent. If they're 4 or 5 years of age, that usually they are, you can explain to them in the diagram what is happening with the GI tract, and what are they doing that is causing this pain that persists and creates more constipation. The non-retentive fecal incontinence, these are patients that actually pass a full stool in their underwear. They usually toilet trained, so it's always seen on 4 years and older. And this is basically, there's no retention of stools. They just put the entire stool in the underwear. And they have normal defecation. They have no abdominal pain, but they have emotional disturbance and impulsive action triggered by unconscious anger. So these are patients that have some psychiatric baseline as a reason for this particular just behavior. Is quite commonly on patients that has been sexually abused, quite frequent. Actually, the ones that I've seen are mostly secondary sexually abused. The treatment is identify these disabilities, psychosocial disturbance, sexual abuse, and then recommending behavioral therapy. A third of them will do better by 2 years of age, but still 5% will still have problems by age 18 years. So I'm going to do 2 questions quickly and then close. The first MOC question is for a 10-year-old female with 3 episodes of severe acute nausea, non-bilious vomiting lasting for 2 days in the last 6 months, debilitating symptoms, unable to eat or drink, seen in the ER 3 times, should rehydrated, history of headaches, but not related to the vomiting. Each episode has been linked to prior participating in school baseball games. So that means that there's some stressors there. There's no fever, no family contacts with any illness. And once the vomiting resolves, she's fine. So the most likely diagnosis is migraine headaches, B, abdominal migraine, C, cyclic vomiting syndrome, D, functional vomiting, and E, functional nausea. So I'm just going to tell you that the diagnosis is actually, I'm sorry, the selection is C, cyclic vomiting syndrome. So you see it's 6 months apart. There are stressors involved. She's finding between these episodes, and it was severe enough that she needed ER evaluation with hydration, because they vomit until they get dry. The second question, 7-year-old girl with 2-month history of daily nausea not related to any meals and not consistent associated with vomiting. It's vague abdominal discomfort, occasional vomiting. She's able to do her own thing, her own routine work. The nausea gets worse at night, probably because she's worried about the next day. No weight loss, diarrhea, constipation, normal physical exam. So the most likely diagnosis is functional abdominal pain, functional nausea, cyclic vomiting syndrome, abdominal pain, abdominal migraine, or functional vomiting. And this is the typical patient with functional nausea. I'm going to go for the last home take points with, we're going to say that the characterization of pediatric functional GI disorder has evolved in the last 2 decades. So now we can identify this particular patient with a diagnostic criteria. A symptom-based diagnosis and more available research has helped to chart criteria for functional GI disorders now with ROM4. So the removal of the dictum of no evidence of organic disease, to diagnose dysfunctional disorders, to a new one called for, after appropriate medical evaluation, the symptoms cannot be attributed to any other medical condition. So you have the freedom of saying, okay, I have enough experience, I feel comfortable treating this by clinical symptoms, but always keep in mind there are few cases like for example, cyclic vomiting syndrome, abdominal migraine, that you may keep in mind that you may need some selective studies to be sure that you're not dealing with any other metabolic or other uncommon disorder. Review psychosocial risk during your interview is very important in order for you to highlight stressors triggering these functional disorders. You have to take the time to actually look and ask how things are going at home or how things are going at school. And the history and physical exam are the tools to bring the art of clinical diagnosis for functional GI disorders. So basically, by a good history and good physical exam will give us a lot of information. So never forget reviewing alarming red flags of disease that you can actually diagnose other conditions that are totally organic in your differential diagnosis. I have to say, lastly, that there are patients that may have Crohn's disease or may have celiac disease or may have other organic disease, but also has a functional disorder at the same time, which makes practice a little bit more challenging, but you have to keep that in mind. So there are patients that can have a functional disorder in top of an actual organic disease. Thank you for your attention.